This episode is sponsored by Romanwell. Living with IBD can be all-consuming, and the existing healthcare system is not set up to provide patients with the ongoing support they need. The dietitians at Romanwell believe that all people with IBD deserve access to the highest quality, evidence-based care available. They also know there's no one-size-fits-all solution to IBD, but there is one that fits you. If you're interested in getting back to living your best life instead of living under the constraints of your disease, head on over to romanwell.com to apply for a complimentary consultation and tell them Alicia and Robin sent you.
Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to licensed clinical social worker Courtney Robert. She's the therapist for GI Alliance in Baton Rouge. We talked to her about post-traumatic stress and trauma and inflammatory bowel disease, and we spend the vast majority of our time talking to her about a psychological technique called EMDR, which stands for eye movement desensitization and reprocessing. It's used often for helping people with their trauma. We learned so much from Courtney, and I know you will too. Cheers.
Hi guys, it's Robin. Welcome to the show.
Hey guys, this is Alicia, and we are very delighted to have with us Courtney Robert. Courtney, welcome to the show. You were invited to the show by one of our favorite people, Stacy, and we are so stoked to have you on. But before we get to know you professionally, because you are one of our healthcare professionals, we start out with the very unprofessional question of what are you drinking?
I am drinking a gin and pink grapefruit soda.
Oh, yummy. Love that.
Yeah.
Is that officially a Greyhound or is a Greyhound with grapefruit juice?
I don't know. I
Okay.
was sitting there. I was like, this has to be something because it's really good. But I was going to go gin and tonic. And then we had this, a friend of mine had brought over the pink grapefruit soda. And I was like, oh no, we're going to do this instead. So whatever it is, it works for me.
I love it. Yeah, I'm a big fan of gin and I'm a big fan of grapefruit, which I know is a controversial topic for people, but I love a Greyhound, or grapefruit and gin together is delightful.
Yes.
Robin, what are you drinking?
I am drinking water.
Good for you. Hydration is key.
Stay hydrated. Yes, it's really humid. I need to stay hydrated.
Understandable. I am going with the old standby. I'm drinking Champs again.
Courtney, welcome to the show. We're so happy to have you here. Now it's time. The second question, a little bit more professional. How are you connected to the IBD community?
So I kind of got involved with IBD in a little bit of a roundabout way. So my background's in social work. Before graduation, did my second internship at one of our hospitals here in Baton Rouge. And towards the end of that internship, it was mostly like discharge planning. I knew I always had an interest in like the medical arena, but wasn't exactly sure on what I wanted to do within it. But got introduced towards the end of that internship to a physician he's a rock star physician. He's ultimately who kind of introduced me to this clinic. But so he created a model in this clinic. He was an administrator, but also in practice. And he created a model that was focused on chronic disease, but it was kind of more in a broad way, I guess. It was a lot of like diabetes, hypertension, obesity, a lot of metabolic issues. But the model was, let's take the most complex patients, let's put the resources that they actually need for, if it's behavioral modification for that, if it's actually following appropriate algorithms for the improvements that they need to be making. He put all the pieces together. So in that one, we had a physician, we had mid-level providers, we had a dietitian, we had a diabetes nurse educator, we had myself, and we just all worked under the same roof. And so over time, I did that for the first several years, and we did it with our own employees, because we had our own health plan. So we were able to kind of manage it well that way. And so from there, that was Dr. Kenny Cole. He knows Dr. Casey Chapman, who works with solely IBD, and they were able to kind of coordinate, collaborate, and recognize that his patients with IBD would benefit from this model. And since then, kind of shifted over to just seeing IBD. It started as kind of like a trickle in kind of thing, because we were still working within that main clinic, but we'd see some of his patients that way. And then eventually really just made that full transition over to IBD. And so we've been doing, I think I started seeing individuals with IBD probably 2017, I want to say, which it doesn't feel like it was that long ago. And then I start to realize that time makes no sense anymore. But so started doing that then. And then, like I said, now at this point, I'm just working with IBD, and it's the same, these days, it's the same model. So we got, Dr. Chapman is kind of physician lead. We've got mid-level providers. We've got myself. We've got a dietitian kind of roped in there. We've actually got a primary care doc who sees just IBD right now too, which has been a really cool addition too. So it's, you were able to really just concentrate and pull some pieces together for these people. So
I love that you added the primary care doc, because it took me forever to find a primary care doctor that was familiar enough with IBD that I felt comfortable going to them for the regular routine stuff.
Yeah.
Stacy and I laugh about the fact that our GI is our primary care. Our primary care is just for show, for insurance. But, when I did find a primary care who was familiar with IBD and I trusted them and I felt comfortable going with them, it was such a game changer. I felt like I had a real team taking care of me and I didn't have to go to my GI for every single thing. So I love that there's a primary care doctor as a part of the team.
Yeah. And that happens often, right? Where we've been seeing someone who's been seeing their GI doc for years, and we'll say, okay, something comes up that normally would fall under a primary care provider's umbrella, I guess. And you ask, and they're like, no, I don't have one. I've just been seeing him. That's where I got my labs done. I do that regularly anyway, so I don't need one, or just haven't seen one up until now. I'm telling you, when we started in that initial clinic, it was huge to be in the position of a social worker, but to have that connection with the primary care provider who a lot of times was prescribing medications for anxiety or depression or different things like that. And then we had that coordination to where we could communicate. And so he could check in with me, I could check in with him. And now roping that into this arena has been a game changer for sure. So it's huge.
As a fellow social worker, yay, social workers. Social work really encompasses a whole variety of roles. So first thing that you say in hospital social worker or like healthcare social worker, I think case manager, somebody who tries to seek out resources, tries to help with like prior authorizations and all the sort of that baloney sort of stuff. But also within the healthcare setting, there's like therapists and people who provide actual mental health counseling that are also social workers that usually have an additional training beyond what I did. So what is your role? Is it a little bit of both? Is it one or the other? Talk to me about what type of social worker, quote unquote, you are.
So what's interesting about this model is that there's room for a few different approaches, because like you said, in the world of social work, you can do so much, which often ends up being the reason why people are like, oh, just give it to the social worker to do, right? And in this one, the way that it's evolved over time, at this point, we have an RN care coordinator who ends up doing a lot of the things in some other arenas you may have social workers doing. A lot, they can do the prior authorizations, they can do a lot of this, just kind of pulling all the pieces together, coordinating care. And what that's allowed to happen is for me to just end up providing, for the most part, clinical psychotherapy, clinical counseling. So it's allowed me to be able to really just concentrate in that area, which has been cool, because you get to do that, but while also being part of the multidisciplinary team. There's moments where there's overlap. If you've got some individuals who are dealing with just natural issues that end up coming up with this, financial issues, or, different kind of socioeconomic issues that just naturally pop up, it kind of can fall into that. But for the most part, it's direct counseling.
That's awesome. I think having the skills of both is really key, just because I think there are times where, like you said, you're talking to somebody and about their stress or their anxiety. And if their anxiety is around finding transportation or paying for your medications, it's nice to be able to offer a resource instead of just saying that must be very hard for you, and doing your empathetic side of that. So it's nice to be able to do both.
Right. It sounds like that's really hard. And tell me more. Yeah.
Yep.
Mm-hmm.
And here's a resource for you to try. Let's stay with the social work, because of course, I love it. Tell me more about being integrated into the team. What does that mean? Like, say Robin decided to go see Dr. Chapman and she walks in the door. She's a brand new patient to you. Do you automatically meet her? Does Dr. Chapman or the nurses say, hey, I think actually this person could benefit? How does that function within your team?
Yeah. So if you were to follow it from new patient walking in the door, and again, one of the benefits of this model, and I think something that I've tried to emphasize to patients who are starting in to this, is that it should not function like you're used to. If you run into something that's not working, we have room to be able to change it, and we should change it, right? So it's like trying to give them permission to speak up, when they're seeing something that's not working well. That's how this should work. It's how healthcare in general should work, and period. But here we are. But that's how this should function. So I try to emphasize that when they finally do, if they do come to me. But from the moment they would walk in the door, if they are seeing Dr. Chapman for the first time as their GI provider, right? For our clinic, they have to have a diagnosis of Crohn's or ulcerative colitis, or it's assumed that they do, and they're kind of doing the work to really figure that out. So if they go in there, generally they're going to do a few different questionnaires. They're going to do an SIBDQ questionnaire. They're going to do a PHQ-9 that's going to be focused on depressive symptoms. They're going to do a GAD-7 that's going to be focused on symptoms of anxiety. And that's for any of our patients who walk in the door. And what that'll generally do is kind of raise a flag if it reaches that threshold of, or at least it can start the conversation, but also, if if it's reaching that threshold of saying, okay, there's something going on here, that's when they'll bring up the conversation of, having me there as a resource, built in, same clinic, same floor, just right down the hallway. But there are times where people don't feel maybe safe enough to answer as honestly as maybe they would benefit from on those questionnaires. Sometimes I've had some people come in, just like draw a straight line from 1 through 9 or 1 through 7. And I'm like, I don't know that you read those, so it just depends. If that's the case and the provider is just kind of catching on to a trend of something more going on, they'll bring it up as a conversation. And then kind of same thing with the primary care side, because he does a pretty thorough, like looking at the entire person. Those conversations come up. He'll ask about history there, and they bring it up as an option too, just kind of as an introduction to the clinic too, letting them know what all they've got at their kind of disposal.
So Robin and I talk a lot about therapy on the show, and I jokingly told you that I don't know that we're the best poster children for people who are good at going to therapy, but we really like to tell people to do it.
I do it.
You do. Robin is putting in very hard work. Yes, I give you a lot of credit for that. I am running away from it still. It's been a long time since I talked to my therapist, but I'm curious because we haven't had a chance to talk to either of the other mental health providers that have been on the show. Is if somebody is new to therapy, how do you talk to them about it? How do you prepare them for what to expect when you're going to start therapy?
Yeah, I find, interestingly enough, and mostly because of the way that this clinic is set up, if someone's coming in my door for the first time, the natural conversation of, have you done this kind of thing before, comes up. And I don't know, we haven't pulled like a stat on it or anything, but it's interesting how many people that I'm seeing have never done it before. And I think it's natural that it would happen that way because of the way this model is set up. Like rarely would you find yourself having someone offered to you that they say is like, they're built into our IBD clinic. She only sees people who have IBD. You have IBD. Would you want to see her? And so for maybe the first time that's been offered to them in that way, as opposed to maybe them seeing some other provider or someone else bringing up the idea of therapy in their life and them saying, okay, well, how do I go find that? And so what we end up doing, we'll kind of start to have that conversation of, what's their background with this? And like I said, a lot of times they haven't. So my biggest thing in that first visit is just to kind of normalize it, but also just to put it in their court, that it's just because it is here as an option does not mean it's something that they have to do. That's kind of something I've battled a little bit with on my end, is like, how much do you chase people down on my end, right? Because you can definitely guilt people to coming into the door, right? They're kind of having to come to this clinic anyway. So you kind of have to be careful of like, oh, you were on our social worker schedule, but I see you didn't come. And like, a lot of times, if you're not ready, you're not ready. So I've kind of ended up really leaning more towards, and I tell them this, like, where I am, we're meeting. If what you need from me is to kind of stay on that, let's talk about it. But I really want it to be your choice. I want this to be something you want to do, because we know there's just not as much benefit if I'm having to like make you want to be here, So I try to, like I said, do that, try to make sure that they know that it's kind of something that really it's available to anyone who's coming into the clinic, just to normalize that a little bit. And a lot of times the way we end up kicking it off, I tell them, that I only end up seeing people within this clinic. And so a lot of times we will start off by kind of getting their take on their history with IBD, which on one hand, I know they've probably told the story 5 million times, but on the other hand, if I just go back through their chart, you miss a huge piece of that personal experience that's kind of come from it, right? We can see like, okay, there was a hospitalization here, but all we're left to do is just assume how that was for them, So a lot of times we'll kind of kick it off that way. And then really I'm making a point to say, what is it that you want from this piece, And that varies a lot. So I always tell people, I'm like, the one unifying characteristic of everyone who comes in here is that they have IBD. And whereas that might be the center of your conversation in some of these other providers' offices, and here my mind works in images, but for me, it's like a bicycle wheel, right? Like IBD is just kind of one spoke. And so they are sitting there at the middle. The IBD is a piece of it, but rarely is it the only spoke on the wheel. And so making sure that they know it's, anything kind of fits there.
I really like the idea because it sounds like the way you approach it and the way the clinic kind of approaches this is putting the patient in the driver's seat and really saying, you get to decide, do you want to meet with the primary care doctor? You get to decide if something is wrong and be open about that. You get to decide if you want to see the social worker, you want care management, whatever it is. So I love that concept. I'm curious if that has translated to any data that would show that these people have like higher rates of satisfaction or higher rates of like treatment adherence or things like that kind of have that like clinical data attached to it. Is that something you guys are exploring, or I'm assuming you're looking at that?
Working on it. I will say data collection has probably been our biggest difficulty. It mostly comes down, I think, to like EMR and just like capabilities, which clinically are talking about today, actually, about how necessary it is to be able to really prove the benefits of what we're doing, right? And so we have people who are working with it. I know back whenever we were doing it within the other model, they had some numbers that they had pulled just from outcomes whenever you are engaging patients in this way. And especially when it comes to the social work role, it's interesting because it's not a money maker, right, for a clinic like this. And this is where you end up having to kind of figure out, like, it generally is not, there are ways that people are figuring out how to do this, but sometimes models like this are a hard sell to the healthcare powers that be, who are used to systems that make money on volume, right? And so when you say, okay, well, we're going to need to pay for a social worker to come on, and of course the question is, like, how much are they going to make us? And realistically, a lot of times you're not making a lot of money off of having me there, right? The idea is that there are savings that are involved in that. If you are engaging a person in their healthcare, if you are empowering a person to help themselves within their healthcare, if you are talking about medication adherence, and if all of a sudden it took one conversation to figure out why someone's not doing their Humira injections, and it's because there was some sort of anxiety around that, well, like, we can have a conversation and figure out how to manage that, So then all of a sudden, everyone wins on that end, everyone that needs to win for our healthcare system in the current way that it functions, right? So we've got, pharmaceutical companies win that way, your healthcare system wins that way, but ultimately the patient wins that way. Data is important, but you have lots of eyes that are starting to look at a model like this because of how beneficial they're recognizing it is for everybody involved, if you've just got this one piece plugged in. So it's pretty cool when you look at it that way.
Yeah, that is really cool. But I also know the challenge probably is that part of what you need to get that data is patient self-report. And so, and people are like notoriously bad for doing surveys. They're like, ugh, I'm not going to do this. I'm delete email, and so I'm sure there's a lot of people not reporting on, oh yeah, I'm not doing this thing that I used to do. Like, I stopped smoking because it's bad for my Crohn's disease or whatever it is. It's, it's harder to quantify that. I think, nobody
important
wants
data, but hard to get.
Yeah. And nobody wants to be like, no, I'm definitely not following my doctor's recommendations,
right.
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 Nobody wants
except for if you're me.
You are, Robin, you are faultlessly honest, which I think is a really great quality to have. And frankly, more patients need to learn from you because data would be much more robust.
I would like to dive in because I got to talk to Courtney before we scheduled our actual interview. Again, because Alicia and I did not know you.
Right.
And we learned early on that we should probably screen people.
You make it sound like we had some sort of like bad experience. It was, so far, everything's been fine.
Stranger danger, Alicia, stranger danger.
You know what? I think Courtney can help you with that.
we can talk about that. Just tell me how it makes you feel.
So we got to talk before this conversation today, and we talked about the new research into PTS and the training that you underwent to implement into your practice there. And I would really love to get to dive into there. Could you tell us about that?
Yeah. So
Courtney, hang on 2 seconds. But some folks, if they missed our episode with Tiffany Taft, they may not be aware of what PTS is. So can you start by talking about what is PTS in the context of inflammatory bowel disease, and then talk about what Robin asked you, please?
Yes. So basically what we're looking at is trauma experiences, post-traumatic stress, right? And you've got some great people who are doing, like Tiffany, who are doing a very important research on this, right? And looking at how can we make a difference with people who are experiencing this. So what we end up, I'll kind of insert some of what she was talking about in hers, and then we'll kind of go into how this approach that I'm looking at here is working, I guess. So when you have these researchers who are in GI psych who are looking at some of the top ways to integrate mental health care, behavioral health care, they're looking at, what can we look at and say are the most effective ways to manage medical trauma, to manage stress, to manage, whatever we can help these individuals who are dealing with this with. They found that there are very specific approaches that they're able to get good data on, that like cognitive behavioral therapy, acceptance and commitment therapy, and gut-directed hypnotherapy as some of the top ways. And so when we look at this population, we're seeing, with these experiences that these people are coming away with signs of post-traumatic stress, right? So the hard part about this is that it, obviously, as it would with anybody, it varies so much much from individual to individual and what this looks like. But in my own, I guess, more like kind of anecdotal experience, what this may look like is someone who, who grew up with IBD, who, had to have procedures done as a child, which led to probably lots of different things. I'm trying to kind of configure a vague image of a few different things that I've heard in my experience, but kind of in a situation where you were powerless to an extent, right? And powerless over your disease, powerless over how your disease was treated. Your parents are doing the best they can for you by trying to figure out what can happen. And so we're having to get diagnostic tests and scopes and different things done. But as a child, it's like, you don't have the power there. You just don't. And for some people, lifespan wise, that the issues kind of can stem from there. And so on my end, what that can end up looking like is maybe having people who are struggling to advocate for themselves as adults out of fear of, if I ask about this symptom, does that end up unfolding to another procedure that I don't want done, And so you can see it present in many different ways in many different people. But one treatment approach that there is not yet good data on to treat post-traumatic stress in patients with IBD specifically is a treatment called EMDR. So it stands for eye movement desensitization and reprocessing. The interesting thing here is that there's obviously growing data on trauma within the experience of IBD, the medical trauma that's related to that, right? There is loads of data behind EMDR as a treatment for trauma, but no one's really put that together yet. So there's really not the data we need to be able to say this does directly treat, and it is like a dependable data-driven treatment option for IBD related trauma, right? So we don't have that data yet. Interestingly enough, though, obviously we see different experiences, different medical trauma experiences, I guess, kind of coming through our doors. But what started my gears turning with EMDR was, having person after person after person. And this really stemmed back to maybe even that clinic that I saw before, with just the metabolic diseases and things like that, there was just this consistency of, and as we know with data here too, is that it is not abnormal for people who are dealing with chronic conditions to maybe have some sort of history there with some very challenging life experiences, whether it's adverse childhood experiences or things that happen later on, right? So what we kept seeing was people who were dealing with some really hard stuff. And what we know about EMDR is that it can be effective in managing that, And so like I said earlier, when someone comes in to see me, we don't have to just focus on their IBD and what we do. We can, obviously, absolutely. But if there's some stuff that started happening even before that, we can apply this there. So with EMDR, this approach was interesting. So what that ended up leading to was me starting to kind of really see where that was maybe a missing piece that I needed to do more to be able to provide for these individuals, right? And so I was having conversations with Dr. Chapman. There was a missing piece. And I kept kicking myself because last year there was a training that came to Baton Rouge that it was an EMDR training, and I went to go sign up and they had already gotten full. And I was upset because I was like, it's kind of one of those, you can do it virtually, but I felt like for me, I needed that in person. And I'm so glad that I did the in person, even if it took, a year later to do it, because what I got from the training was just, as far as how it's impacted how I practice, was significant.
I mean, and I said this to you before we started, because EMDR is wild. It doesn't seem like something that should be a treatment.
I know.
It means it's right. I'm assuming when you tell people about it, they're like, you want me to do what? Because it's eye movement,
desensitization, and
yes.
So yeah, when I tell people about it, they're like, so hypnosis. And I'm like, well, right. No. And it does. I have to kind of preface it sometimes with okay, I know this is going to sound woo woo, but let me take a second to explain this to you. And let's talk about how much data exists on how beneficial this is. And that's what's crazy about it, is they're able to pull so much information on how beneficial this has been for people, right? And so they've been doing EMDR, I want to say since late 80s, early 90s. And again, I wouldn't quote this. I want to say one of the first people they used this with was someone, it was maybe a Vietnam veteran. And there are a few different pieces to this. So the way that I kind of explain it when someone's coming in, because I want to make sure that they know what we can do within this clinic, and know that this is an option, nothing that they have to do if it's just not their jam, but that it can be something that could be beneficial. And sometimes we'll take an example that they came in with and say, how would that fit into this model? So it's broken into a few different phases. So when you're starting, there is a phase called resourcing. So what that basically is, and the way that, at least the way that I use it, is you're talking about a lot of the ways to manage difficult emotions. A lot of that comes down to, we usually take a visit or two to kind of really get familiar with the nervous system. And I have to preface it sometimes with them. I'm like, this is going to feel like a biology lesson that you didn't ask for, but I promise there's value in it. There's value value in understanding why we get these physiological responses to stress, right? And so we do a lot of talking about your sympathetic nervous system, your parasympathetic nervous system, how to notice each of these states, how to notice if we go from your ventral vagal system to your sympathetic to the dorsal shutdown mode. And we talk about all these little details, and I try to map it out as well as I can for them to be able to kind of just recognize. And then there was a training I had done on that specifically that had us do each of the things that we would end up having someone else in our practice do. And one of these was called polyvagal mapping. So it was breaking down each of those tiers and saying, okay, how am I whenever my sympathetic nervous system is kind of taking the front seat? So when I'm in that fight or flight state, what does that look like for me? How do I hold my body? What do I feel in my body? What do my thoughts look like? How do I interact with other people? What does my eating look like? What does my sleeping look like? Like everything that could exist in that state. So we do that for that sympathetic state. We do that for that dorsal state that I usually will call like that shutdown mode that for a lot of people looks like depression. We'll talk about how sometimes when we hit that kind of okay, I can't resolve this problem, or the system has become totally overwhelmed, or we're just under such a threat that our systems don't feel like they can manage it, that we'll go into that shutdown mode, which you'll find happens a lot with people who are dealing with IBD, right? Because it feels like this threat that is so odd because you can feel it, but you can't see it. But at the same time, you don't always know what state it's in either. And you're trying to do what you can to manage it. And then here we are hurting again, so there's all of these things that can lead a person to that shutdown mode. And so a lot of times when we're going through that, you'll have people that are saying, I never leave that red space. So there's a chart that I use that's kind of got it broken down in by color. So there's like a green zone, a red zone, and a blue zone. And so I'll be I never leave that red zone. I'm constantly in that fight or flight state, right? Or you have other people who are I know that blue zone, that shutdown mode. I know that very well, And so we have a conversation about that, trying to figure out what is it for their system that helps them complete that stress cycle. And so I'll reference, Brene Brown, the queen, right? And she had on a couple of researchers, they're the Nagoski sisters. So she had them on her podcast and was talking about this whole concept. So I'll tell people a lot of times, if you're not ready to read their book called Burnout, you can go get a highlight version with the podcast. And there's an even shorter version in an article that's in Woman's Magazine that kind of highlights this too. So we'll talk about that. We start off in that resourcing phase. I make a point to talk about that. We'll talk about different ways that for them help them to regulate their nervous system. When they find that they're in those states, what are ways that help you to get back down to that kind of bounce state? And it's hard because sometimes people are I'm never there. And so you have to kind of explore those micro moments where they are there that they just don't realize, So we do that in resourcing, obviously, things like diaphragmatic breathing, which is just another way to regulate your nervous system, right? Just a lot of these things. There are a couple exercises that are built into EMDR that we do within that as well. I've also started adding in some guided imagery exercises into that phase as well. We can talk, I'll reference that a little bit later. I think gut-directed hypnotherapy is a new thing that I'm kind of trying to dive into too. So we can reference that later as well. But that one, there's a lot that happens in that resourcing phase. And it's very important because when we get into some of these later phases, it is something that you want to have these tools established so that if you're getting to a point where emotionality is high, or you're kind of on a topic that's difficult, or you find that there is some sort of overwhelming response to what we're kind of getting into in this processing phase, that you've got these tools in your pocket to be able to utilize. So if it's something we do one thing, it's called a container exercise. So being able to kind of use some imagery to create this mental image of a container. And if you're having to close off a session or something, or say you're between sessions, you've got this mental image of something that you can put this hard experience into and you can come back to later, kind of thing. So not avoidance, but a tool to be able to intentionally come back when you have the capacity, right? So, okay, long-winded explanation for resourcing. And then we get into this middle phase is what we'd call targeting. So this is where we'd sit down and say, okay, what is the thing? What is the incident? What is the thing that you are wanting to target here? From there, what we'll do is identify the problem. And there's different ways to do this. This kind of cut and dry way would be let's do a little bit of a timeline to look back on this. So I'll use an example just because it's kind of a blank example that maybe anyone could kind of identify with. But if you came into me and you said, okay, Courtney, what I'm trying to work on is every time I get into a vehicle, I find myself feeling just flooded with tension, overwhelmingly anxious. My breathing changes, all of these things. I'm just having trouble getting into the vehicle and driving. And I want to be able to drive. I need to be able to do these things, right? So what we'll kind of do from there is take a little bit of a timeline on that. And we'll say, okay, what are other situations where you've felt the same feeling when you've gotten into a vehicle? And we'll kind of, I don't know, whenever I was 16, got my driver's license, I remember getting into the car and I just felt completely overwhelmed and struggled through that, or we'll kind of keep going back, and you're kind of working your way back and getting to what we'd call like this touchstone experience, either the earliest or like the most intense experience with this. And maybe for this example, it's maybe I was in a wreck when I was 12, right? And it really shook my sense of safety in a vehicle. One thing we also have to do at this point is find what we would call our underlying negative belief that's present here. And this part's really important because this and this next part are very important, but maybe some of the most important parts about this. You've got to find what that underlying negative belief is. Like when I get into a car, what is my belief when I'm in there? If I know I'm feeling this way, what's that negative belief that's present? And if in that example, it's, I just can't be safe in a vehicle, right? Sometimes that part takes a little bit of digging to really figure out what is the negative belief that I actually feel like is kind of at the root of this. So I found that takes a little bit of digging, but the more important part that comes from there is that we find an adaptive belief. And that'll make sense in a second, but we have to find an adaptive belief that we actually have some sort of sense of control over, agency with, I guess. If we're coming up with an alternative adaptive belief, it can't be that, what I would like to believe about this situation is that I will always be safe in a vehicle, right? Because we cannot guarantee that we will always be safe in a vehicle. That would be nice, but there are so many other factors that are outside of our control that we cannot guarantee that. So instead, it could be something like, I can do what I can to keep myself safe in a vehicle, right? There are numerous ways that I can look backwards and say that I've done that throughout my life. I can wear my seatbelt. I can know where I'm going. I can drive when the weather's good. I can orient myself to the vehicle. All of these different things that we've done that make us feel like we can control what we can to keep ourselves safe. So going backwards, so we find that negative belief, we kind of do that timeline a bit, get to that touchstone memory there. What we'll do at that point, like I said, we come up with the adaptive belief. Once we've created that timeline, we've really done a lot of the targeting. We figured out what we're aiming at. We figured out what's this underlying negative belief here. What's the adaptive belief that we want to believe. From here, we'll kind of start to move towards the processing piece. Obviously, throughout this process, you want to keep checking in with the individual, making sure that this is something that they still want to do. They have control the entire time if this is something that they want to do or not. So you make a point to ask, like, is this still something that's interesting to you? Is this still something you want to do? From here, you're kind of constantly gauging that. If this is between sessions, you're constantly revisiting that negative belief, that adaptive belief, making sure they feel like it still fits. It can be something that shifts over time. And we're getting ready to go into what we call the processing phase. That's where this whole eye movement piece, the part that people will say, like, I'm doing EMDR when I'm doing the processing piece, really. And this is something they kind of really emphasized throughout the training, was like the entire thing is EMDR. But what people will say, I want to do that, I think, there are a few different tiers of EMDR that you can do. You can do what we would call like completely unrestricted. So this would be, maybe we start off aiming at this issue with the vehicle accident, right? But once we get into the actual eye movement processing piece that we'll talk about, that like it could go anywhere and you allow it to go anywhere. The idea is like the brain's going to go where it needs to go to fix what it needs to fix, kind of thing. And so you can just let it go. Risk that can come with that is that it can pull on some stuff that you maybe weren't necessarily prepared for it to kind of pull on. Our brains, our bodies, our nervous systems, everything does a really good job of keeping us moving forward and keeping us alive, right? And so sometimes what that includes is maybe like scabbing over some really hard stuff. One way that I usually describe that to people is that sometimes those things still have tethers to our current day experiences, right? So a lot of times we're like, oh, that was old stuff, like doesn't bother me anymore, like whatever. But yet maybe we're seeing these tethers in our current day that are influencing our relationships or influencing our ability to get into the vehicle. Like I didn't think anything happened with that car wreck when I was 12, but here I am struggling to get into a vehicle and I just didn't put it together. So we acknowledge with that unrestricted side that it can be difficult for some people because that open-endedness can be really hard, especially if we know that there's some complex stuff going on under there. So middle tier would be more of like you aim at an arena of things. This would be where you say, we were doing this in terms of maybe like a difficult relationship, right? Where completely unrestricted would, maybe we start with a relationship, but it could go anywhere. This part, maybe it's this relationship with this one person. And that's where we want to contain it to. Now, the most restricted would say maybe it's like one altercation or argument with that one person that we're trying to restrict it to. So that'll make more sense in a second too. So just to know that there's kind of 3 different levels of this that you can do. Once we've identified what we're going to do with that, we're going to take a rating of how disturbing, when you think about this incident, when you think about getting into a vehicle and the anxiety that's produced there, and you think about that negative belief of, I can't be safe in a vehicle. We want to rate how disturbing is that for you on a scale of, it was like 0 to 10, 1 to 10. And a lot of times that starts off pretty high. So what we'll do, and we'll kind of ask if we're doing completely unrestricted, like where you notice that in your body. A lot of this is being kind of aware of like how you notice stress in your body, how you notice tension in your body, how that kind of comes out for you. From there, we'll say there's a lot of these like statements that you'll hear over and over within the MDR, but it may be something like, okay, I want you to do that, take that rating, and then I want you to just go with that. And this is where the eye movement piece comes in at. So this is where they utilize what's called bilateral stimulation. So you can do it a few different ways. You can do eye movements where you wave your fingers in front of their face. They have light bars that you can follow, things like that. But you can also do it virtually, which is really nice as an option, where you can do tapping on either side of your body. So your shoulders or your arms or your knees or things like that. There are points even in office visits where we would align left to left because of the way that it orients your brain. Whenever you're looking towards your left, utilizing that right side of your brain, which is going to be much more in touch with emotions and things like that. So they're very big on making sure you're doing all of these things that kind of set you up in a way for your brain to do what it needs to do to process this information effectively and efficiently. I had one person kind of describe it as it's almost like that the brain struggles sometimes to update old information with new adaptive information, if that makes sense. So kind of like there's like this block that ideally, like this example with the car, right, that our brains would recognize all the other times that we were safe in a vehicle and it would update that, right? But sometimes what happens with trauma is there's like this like barrier that happens that we don't update that old information and show ourselves like, but there have been lots of things that I have managed really well, and these are the things that I have. And the brain does it, obviously it does all of these things because to some extent it's trying to keep you moving forward to protect you, right? And so, we focus a lot of times on the negative in order to keep ourselves alive, but going back to that processing side. So what we do with that is we do a set of bilateral stimulation and then we'll kind of ask, what's coming up for you now. And it's anything. I mean, it could be anything. It's not a lot of dialogue. This is where it's different. So what they'll describe EMDR is as a neurological therapy as opposed to a cognitive therapy. So this is where the difference happens between cognitive behavioral therapy, where we're looking at how our thoughts impact our emotions, that impact our behaviors, and how we can, shift the way that we are thinking about things, how we're talking about things, all of that, right? So a big cognitive, lots of dialogue happens there. With the MDR, it's not. And it feels, I noticed for me when I was going through the training, it almost felt wrong. Like I was like, I don't think I need to talk about this, and there can be room for that. But in the active processing part, it's like a blurb. So if we do bilateral stimulation, I say, what do you notice? It may be, I'm noticing some tension in my stomach. I'm noticing I feel like tight in my chest. And then I'll say, okay, now just go with that. And we'll do bilateral stimulation again. And then 15, 30 seconds, whatever, I'll say, okay, what do you notice now? Well, I just had this one thought about da, 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 and if we're doing that unrestricted, it, like I said, it can kind of go wherever it goes. Once things stop shifting so much, we'll take another rating. We'll see if that intensity level of that disturbance is dropping at all. The idea is that it does start to drop over time. And I noticed in the training, because one part of the training was that we had to be client, clinician, and observer in kind of our groups of threes, which was interesting because like it was ideal that you bring your own stuff to the table, right? And I had in mind what I thought I was going to bring, and all of a sudden something else happened. Didn't really expect it to be an emotional thing, and yet it was, And so it was one of those where it was just like, whoa. And being able to observe the other people doing it too, you were able to see kind of how things shifted throughout that training. And it was really cool that way. So we do a little bit of the bilateral stimulation. So I noticed for me when I was doing the training, I almost felt like this like obligation for the number to drop, And I think that's an important part that I now emphasize to my people. Like, if you feel that obligation, that's what you noticed, like let that be something that comes up, because who knows what door that's going to open if there's this like feeling of like obligation to make sure the therapist is having a good time, or whatever it may be. So literally it's just whatever comes up for you. We'll take another rating. Eventually that gets lower. So that's that kind of desensitization part. And then what we'll do after that, once that gets to a low enough point, we will work on, I guess, intensifying, or losing the word for it, but kind of locking in the adaptive belief. So that's where we'll then move over towards this adaptive belief. One thing that we do with the adaptive belief earlier than this is we put it and we look at other situations and times in which we have seen ourselves live that, right? So it's like, kind of like what I mentioned earlier, if my adaptive belief is that I can do what I can to keep myself safe in a vehicle, we'll look at maybe 4 different instances in which we've done that and how that felt to be able to do something like that. So then what we're going to do is we're going to start off by taking a rating. Okay, when you look at that adaptive belief, how much do you actually believe that, or how true does that feel for you? And you'll do like 1 to 7. A lot of times that starts off pretty low because you would like to believe that, but maybe we're not sure if we do. And so you work to kind of build on that. So again, you do some processing with that. After that's gotten higher, kind of where we would want to get it to, then we are constantly kind of doing back and forth, doing some of that bilateral stimulation. We'll do a body scan, and then you can kind kind of do this a future oriented version of this too, like looking at situations in which this might be helpful in the future or things that you might be concerned about coming up in the future related to the same concern. So I know it's kind of a little bit of a long-winded explanation.
This episode is sponsored by Romanwell. Every patient experiences IBD differently and deserves a care plan that is as unique as they are. Whether you're trying to get into symptom remission, improve your energy levels, or restore your relationship with food, the IBD-focused dietitians at Romanwell are here to help you safely navigate it all. They work closely with you and your existing care team to find the best answers to your toughest questions. And they give you the consistent one-on-one support you need wherever you are on your IBD journey. Visit romanwell.com to learn how high-quality, individualized IBD nutrition care can help you achieve your health goals.
I mean, it sounds like a lot of this is you guiding this process with somebody and you talking them through these pieces. When they're done with their session with you, though, are there ways for them to be able to do this on their own when they're home? Like, is there homework attached?
So that's what's interesting about EMDR. There doesn't, like with CBT, that's a kind of a built-in piece of that there's like things that you're going home to work on to do with this. What's interesting about EMDR is that once you've started the processing piece, your brain's going to do what it needs to do from there. And you actually are really encouraged to have your people, like if you're doing processing in a visit, to encourage them to have some time after a visit to just like decompress, maybe go take a nap, maybe don't go into something very stressful after this because it can be emotionally exacerbating. So I'd say the biggest like homework piece on this is knowing what resources you have if you found that you're getting to a point that you felt overwhelmed by emotion. You know, maybe sometimes if you're comfortable with letting the people around you know that you're doing something like this so that they can know like, okay, maybe I just need to give her a minute afterwards. I have some friends who do this too as like their version of therapy, and they describe it as exhausting. You wouldn't necessarily think it would be, but the brain is doing so much to try and work through some things that it can be very exhausting, and working to update those files, right? So it's working to kind of come to these conclusions of like, maybe I'm actually a little more capable than I really thought. And this is actually evidence of what I am capable of. So yeah, homework there, know your resources, but allow the brain to do what it's going to do. Go take a nap, And there's actually data too, that'll show if it's not necessarily a complex issue, sometimes once you get to that processing piece, there's stuff that shows that it could, like an issue like that could be resolved within one session of EMDR. I wouldn't say that's all of the time, but depending on the circumstance. And they're looking at like saying that like to an extent the problem's resolved. And I'll say in the world of IBD where this has been a little more challenging is like with IBD, it's an ongoing thing, right? Like we can be in a good place with it, but we don't know how to describe. Sometimes it's like the shadow on the wall that like when I look over, I think Dr. Chapman talked about this, gave this example, like when I feel like something's there, I look and nothing's there. But then when I look away, like that shadow's back, and it's just this idea of IBD, like is something else going to drop? What ends up being beneficial is that it equips you to kind of think about that, right? Especially if we do that last piece of looking at potential situations that could come up in the future and how I can be equipped to manage that.
Yeah, I guess I think of, our conversation with Tiffany Taft, where she was talking about how feeding tubes in particular are like very traumatizing for people, and trigger warning for everybody here. I guess I should have said that before. I think about that situation and go, okay, I can definitely see using EMDR to talk somebody through past trauma associated with it, but that doesn't make getting a feeding tube easier in the future. Yes, you may highlight some coping skills when you did it better than others, but what if you've only had one feeding tube and it was traumatizing to you? Then all you have for context is that one traumatic experience. So it sounds like with the EMDR, it helps you get through past trauma. It may not necessarily equip you with sort of tools to use if you're presented with a similar situation, but you have no context. Does that make sense?
Yeah, I think it's why it's important to, and this is a whole other thing, I think it's why it's important for providers to set expectations very clearly with things like this, But with that, I think the important part about that previous traumatic experience is we want to make sure that we've got what was obviously the whole idea of getting a feeding tube can be physically, there's just so much that's happening with it, right? Like we want to make sure if there's something going on, if it was a feeling powerless kind of issue, that's something that we're getting at here, right? Is that maybe something that's in that underlying negative belief piece there? We want to make sure that we're checking on that when it comes to EMDR. Was there some sort of underlying belief that was present, and make sure that we're working through that, because that can be the case that ends up happening a lot of times, right? With things like that is maybe I've felt, these end up being some consistent like things that I've seen, like I've felt powerless, I felt vulnerable, different like negative beliefs that are in that same family when it comes to IBD,
Maybe this is the one for me, Alicia.
Maybe, Robin. Yeah. Honestly, it could be something to explore with your therapist.
I mean, it sounds like it might be.
It's interesting because I hit a point where I was like I left one day after the training and I was like, I think I need to go do this, first of all. And second of all, I think my mom needs to go do this. I think this person needs to go do this. Like, I think all these things where I'm like, anyone could benefit from it, because it doesn't, one thing they talked about is like, when you think about EMDR, we think about what they call like big T traumas, but it doesn't have to be that, you know, like there are realizations that I'm sitting here when I was doing the training and I was like, I really hadn't thought about that this way, or that I'm watching these other people do it. And it starts off like where they have this idea of like, how could that person who I was supposed to trust in my life do this thing to me? And by the end of EMDR, the perspective had shifted. And it was, I wonder what that person didn't have that they then weren't equipped to give me what I needed as a child, you know? So, and a lot of that kind of inner child stuff can come up with this too. When it comes to IBD, you know, there's a lot of those feelings of powerlessness, or like, what does it mean to me to have IBD? What does it mean about me? What does it mean? You know, I may not have control over certain things in the future. What does that mean for me? And one of the things I think is important too, is that we do touch on like how important it is for them to be equipped to regulate their nervous system, right? And that they have tools that they can do, we all do, that we can use to regulate our nervous system when we're getting into situations that are overwhelming, right? And how important that is.
Speaking of that, one of the things you mentioned that you said, let's revisit in a minute, is gut-directed hypnotherapy, which I find hypnotherapy to be so fascinating. And because I think people are like, cluck like a chicken. That's not what this is at all, you know?
Right.
So it sounds like you started to explore this. Tell us about what you've discovered and why this is of interest to you.
First, what I've discovered is that finding evidence-based, like a good spot to go get hypnotherapy training is actually kind of difficult. And you find yourself down some weird rabbit holes on the internet. So this is an interesting thing. This is one of those on that list of like evidence-based, like, you know, specifically for IBD related trauma that is relevant, or that there's actual data to show benefits of this. Right. And so with this, I tell some people when I'm describing it, and I don't know that everyone would describe it this way, but it's almost like with hypnotherapy comes this whole other context. When you say that, like, cluck like a chicken kind of idea, right? The way that I'm kind of interpreting it is like if it was like gut-based mindfulness relaxation kind of idea, but where the hypnotherapy piece comes in at is like basically getting yourself to such a regulated space where your natural defenses are low enough that you can actually absorb beneficial strategies to manage things, right? And so sometimes I think what our nervous systems, our GI systems need are those pockets of respite that can happen, and that things like guided imagery, guided hypnotherapy can kind of give. So, and I know there's a lot of data with that in IBS, but we also know a large percent of people who are dealing with IBD also have IBS, and how stressful that can be to really figure out the difference between flare symptoms and, you know, IBS symptoms, or just something that's more like stress induced or whatever, right? So it's all of these things can just like start this cycle. So if we are recognizing ways to kind of regulate our nervous system and initiate relaxation, that it can be beneficial. That was a piece I've actually I think I've undervalued guided imagery in my practice for a long time, until I started doing more of this EMDR, and I did another training a couple weeks before that was in like mindfulness-based medicine kind of approaches, things like this. And so one of the things I did was a lot of guided imagery in it. And we talked a lot about why that's beneficial. And now that I've been integrating it into kind of this like resourcing phase of EMDR, I found how beneficial it is that, you know, there's an exercise we'll do that's called like a lemon exercise. And it's like a really active guided imagery about this lemon. And to the extent that like you're using all of your senses to imagine this experience, and you can taste the lemon. And what we recognize is that the same parts of the brain that actually in real life would taste that lemon are turned on while you're doing this imaginary work. And if we think about it in terms of that, we can think and recognize that like if we could do that for places that are calming to the body and calming to the mind, right? That like there are just unused tools that we can use in our own individual lives, like at any point in time. There's tons of guided stuff out there that you can use to kind of put yourself in that headspace that then gives the body time to be not in that like fight or flight state, right?
It's also fascinating. And I feel like we've really just scratched the surface. Like you said, like the things you're talking about are not things that when I was probably studying my undergrad in psychology, I was like, oh yeah, we totally talked about this as it relates. It's like, you know, it's talk therapy, it's CBT, it's the usuals, but all of this is newer. And honestly, a lot of the research is coming from the like VA or like veterans space. And so it's really interesting to see how now they're able to say, okay, well, this is translating like this to these other communities that are experiencing trauma, but just in a different way. And yeah, it's really exciting.
Which is what's cool too, because there's also, you know, there is data out there for other health conditions with EMDR and things, right? That there's, you know, with cancer and different things that people have done some of the research. I mean, there's tons, but it's growing. It exists at least. That's the thing with IBD is it's just not there yet. I mean, it can reasonably be assumed like trauma. We're identifying this as trauma. We recognize this as a treatment for trauma, that, you know, we can look and see the benefits of that. And like I said, for a lot of these people, there are things that have been underlying some of this other stuff, even prior to the IBD IBD that becomes relevant for them or helpful.
One of the things I talked to you about right before that we got started is I said, one thing I recognize within our community is that all of our folks are incredibly resilient. But as part of that, there is some minimization of what my experience is versus what other people's experience is. So it's like, well, yes, I have this, but all of these other people have had it much worse. Like I think about our guest, Amy, who was talking about like, she didn't necessarily even feel able to kind of vent about her IBD or use her IBD as like a, hey, I have this thing going on because she hadn't had surgery. And so for her, like surgery was a milestone that once you reached that, then your IBD was serious, And so in her case, I look at her and go, but that doesn't negate all of these other experiences that you've had as somebody living with inflammatory bowel disease. And I see this happen a lot with our folks where it's like, but my IBD isn't that bad. So my IBD doesn't warrant psychological help or mental health help. So give me the very short answer, because I know we're running out of time here. Give me the very short answer of how do you approach that with patients that you see that's like where they're minimizing what's happened to them.
Yeah, it's hard because I think we're kind of wired that way. I think it also I don't know, helps us cope with everything. We want it to not be as bad, right? I think something that in our approach has helped is that it is just built in, right? That like, this is like, I might've mentioned that like for these patients coming in, we're like, no, this is for you. This is for you specifically, actually, because you have IBD. Like we recognize that the entire person is impacted when you're dealing with some sort of chronic health condition. I mean, that's with any chronic health condition. If you're checking off that box, we recognize, I mean, really realistically, everybody's dealing with stuff, right? And anyone can benefit from this. But I think we have to recognize what kind of a toll that having some sort of chronic health condition can take. I feel like using the word normalize it is so these days, but to do that, right? And so I feel like I said, in our clinic, it kind of does that because it's like, no, she literally just sees people with IBD. Like that is her sole designation. But if that's not what you are equipped with, I think it's sitting there and realizing that like, if you're having to spend mental and physical energy on managing a disease process, it doesn't matter, if you feel like it compares to someone else's story of it. And the reality with IBD, right, is that you really just can't do that, everyone's situation with it is so different that you have to take a second to say, is this something that I could potentially benefit from? But then the hard part is finding people out there who work with chronic disease. They exist. You just kind of have to do a little bit of the hunt to find it. And it can be a huge value. And it, like I said, doesn't matter if it's IBD, doesn't matter if it's diabetes. We recognize that with chronic disease, there are things that happen that are taxing on the system, that having space to manage that is invaluable.
Absolutely. Well, Courtney, we are out of time with you. So last question for you. And since you're a healthcare provider and you work with doctors and you work with patients, so I'm going to ask you, what are the two pieces of advice that you have, one for patients and one for healthcare providers that you have for our IBD community?
I think in the patient aspect, I think, like you said, I mean, you hit the nail on the head, is recognize when you might be minimizing experience or comparing your experience and see what kind of resources are out there to manage that. Like I said, they exist. They can be hard to find. And it doesn't have to be a lifetime commitment. Just be curious about it. Maybe that's it right there, right? Is like, be curious about it and ask yourself, what could I possibly gain from that? What's the result of staying where I'm at and not doing it? What could potentially be the result of doing something a little bit different, And with providers, it's kind of the same. I mean, I don't know. There's a whole, we would get into a whole nother talk about healthcare systems and the problems that are there. But part of me really wants to see these models growing and openness to these models growing, but like having physician leads who have the buy-in to this and that are open to changing the way that these models work, or like utilizing models like this that don't just fit into the current mold, because the current mold really is just not working. And when we're dealing with chronic disease, we need a little more than what we're currently working with. So I think when it comes to providers, it's like, just commit to it and follow through,
Yes. And I think the value of having you as part of the team is key, because I know people who have a therapist, but that therapist doesn't necessarily talk to their gastroenterologist or their doctors or these other people. And so everything sort of happens in a vacuum, and there isn't that dialogue of, okay, this is you as the therapist understand that somebody is struggling over here. And so maybe it is time to do a medication change or to add a medication that could be beneficial, but you can't prescribe the medication,
right?
Because you're a therapist, not a prescriber. And so how do you work with, having that person integrated in is a great way to make sure that there's nothing that gets missed. There's no balls that get dropped. And so I think that's really important. Yeah. And so this type of model seems like it minimizes those risks.
Yeah. And I hope it grows, because I know we see it, with other missing pieces all the time, right? I notice this comes up often with like in the world of like OBGYNs. And I know there's a lot of risk, and there's like people say like, I don't know what to do with this, or they're like, they've had surgery. And so what do I do? But if this person's here wanting answers related to fertility, and then no one's wanting to like communicate. So it's like, there are some of these very important missing pieces that I think, that we're just not the beginning of, and trying to figure out how can we integrate all of this so that the entire person's really being looked at here.
Yep. Well, Courtney, thank you so very much. So we're going to end this podcast by, again, thank you so much for joining us. Thank you everyone for listening to the podcast. And so we're going to say cheers.
Cheers. Thank y'all so much. Hey, this is Courtney. If you enjoyed this episode, please rate, review, subscribe, and share with a friend.